This is the Heartland Daily Podcast.
Hello, and welcome to the Heartland Daily Podcast. This is Anne Marie Schieber from Healthcare News. Well, it has been 14 months since the COVID-19 pandemic began, and researchers, scientists, doctors, economists, and the public say it is all time to return back to normal after 14 months. We know what has worked and what is not working. We have no reason to fear. We have no more reasons for top down approaches. With me to talk about that is Paul Alexander, who is a health research methodologist in evidence based medicine at McMaster University in Toronto, Canada. He holds degrees in epidemiology and evidence based medicine from McMaster and Oxford. And with the help of two other contributors, he recently published an 18-step pathway moving forward from COVID-19. I love this list because it has taken a lot of these ideas and put them in one easy-to-read document. Welcome, Dr. Alexander.
Hi, thanks for having me. Thank you very much.
Well, I first learned your name on this listserv that you and I are on, the C19 email listserv. It's been very educational to me, and you are one of the major contributors. Do you want to tell our audience first what this is and how it might have helped you in coming up with this pandemic pathway moving forward?
Okay, thanks very much again. Well, essentially, this group of scientists and doctors was forged out of a concern for the lack of treatment, therapeutic treatment for persons with who tested positive, high-risk patients who tested positive for COVID-19 and were initially symptomatic. So mild symptoms, probably in the first, second day, etc. And we were talking about patients who were in nursing homes, long-term care facilities, assisted living, or even in their private homes. So we were originally talking about people who were advanced stage and generally would have underlying medical conditions. But we also recognize that COVID in its march forward gives way to age, that if you were younger but you had medical conditions, you could be at risk, as well as COVID has demonstrated that obesity, excess body weight, is probably one of the principal risk factors. So we were finding that there were these therapeutics, sequence combined approach where we would use antiviral drugs combined with corticosteroids, combined with antithrombotic, anti-clotting drugs. And these were dramatically dropping the risk of hospitalization and death 85-90%. So it was very startling. And the challenge was that while there were clinicians across America who were using it, it was not supported by the medical establishment and the FDA. So this group of doctors began discussing, how we can go forward, how we can educate clinicians to use their clinical discretion once again, and to be brave enough, because they have the authority, clinicians, to use these therapeutics, because we are talking about existing available drugs that are safe, cheap, accessible, and effective. So why not use it, and why not try to save lives? So we came together, and the group has kept growing, and we meet, we email, we have meetings, we discuss, and we're using the most updated evidence to base our discussions. But at the end of the day, it's just we're trying to save lives, and that's what this is about.
Right. Yeah, and it gets really into the nitty gritty. Just the information that these physicians and experts share has been really educational. In your opinion, what is the biggest lesson learned from our public response to COVID?
I think the biggest lesson learned, two things for me looking back. Let's say, take off the scientific, the research hat and put on just a layman, even a father, a parent, or a husband, whatever, a normal person's hat. What shocked me is that the ease at which the American people or the Canadian or British or citizens in a country would just acquiesce to what their governments or their public health officials would say without pushing back and standing up. That stunned me. And also the second thing that I think I learned is the hubris and the arrogance and the ego of the public health officials and clinical doctors and scientists who have stood by or stood on the fence, have not helped, and actually some have worked against efforts of clinicians such as the C19 group who are trying to save lives. Because the question becomes this. This is the key issue that started us. When someone is infected with COVID, like other viral illnesses, etc., but we're talking about COVID. When you're infected, normally, the normal sequences from about 10 to 12 to, let's say, at most 14 days post-infection, you are literally, I'll break it in layman's terms, on a COVID train. You have begun on a train forward, depending on your age and your risk factors. So, if you are a young person, healthy person, no risk factors, your train is going to take that track eventually where you're going to have no symptoms or very mild symptoms, like if you had a common cold, etc. But if you have serious underlying medical conditions, if you're at an advanced age, if you're seriously morbidly obese, as you move along those 10 to 12 to 14 days I mentioned earlier, your train is going to veer onto the track where you will more certainly get severely ill. That's the issue. The question becomes, as you are moving along that track, when you did go to your doctor in the clinic, or you did go to the emergency room after the second day, you're feeling a little crappy, you went to the ER, they checked your temperature, they say, well, you're not that badly off, go home and take some ibuprofen, drink some soup, relax at home, and if you worsen, come back. That's what the doctor will tell you. And that's the problem, because you who have these risk factors, we know you're on a train that's going to veer right towards severe sequelae. So our input will stop Mr. Medical Profession, because these people are going to get severely ill and they will potentially die. Once you enter the emergency room severely ill, your risk of death goes up 25% just across the door, just because you got there in your car or the ambulance. Just that. And it's downhill from there.
And it's amazing to me because the power just really kind of trickled down through the whole system. We just had a handful of agencies that basically put the clamp on early treatment, and that trickled down to all the institutions, all the providers, and they were all acting the same way, and a lot of people died as a result. I want to kind of skip over because we got a lot to cover. You're neutral on vaccines, it seems, but say that they really would not have been necessary if we had followed some very basic steps early on. Can you explain that?
Well, let me say something quickly as I answer that question. You need to understand a key fact, or whoever is listening. The average life expectancy in the United States or in Canada or even Great Britain is roughly around 80 years, 80 and a half, etc. But the median age of death for COVID is 82. So the reality is COVID kills people beyond their actual life expectancy. So this is not a pathogen that's taking life from you. That's the key.
Yes. Okay.
So when you look at it like that, it puts things in perspective. It makes you understand.
That is
what the media has done here in the fear and everything. I mean, this has a perspective on our context. You need to understand. So anyway, let me address that question. So here's the issue, and I'll begin to answer it this way to you. If you had a population of 1,000 people, closed population, let's say you're on an island somewhere in the Pacific, closed. It's everybody on that island is living there, 1,000 people, self-sufficient. The average age on that island is 40. The eldest person, the oldest person is 55. No one has any medical conditions. Everyone is healthy. and no one is overweight or obese. If COVID managed to come to that island, it will probably run through the island and infect people. But at the end of it, no one will die and no one will get severely ill. The issue with COVID is it's not the lethality of the pathogen. The SARS-2 virus is not more lethal than SARS-1 that we dealt with in 2003. SARS-1 in 2003 was far more lethal with a case fatality rate.
Really?
Yes, SARS-1 had a mortality rate of 10%. Yeah. The mortality rate right now of SARS-2, infection fatality rate is 0.1. And if you are less than 70, it's 0.05, half of that. So we are talking about a far less lethal pathogen than SARS-1. That's very, very good news. Yeah. So the issue I'm saying is, in a healthy population, this would be no problem. COVID has demonstrated that the United States, Canada, Britain, France, all of the countries have very unhealthy populations, very overweight populations. COVID has revealed that we don't really have a pandemic, we have a fatdemic. Obesity. No, I'm trying to be, I'm answering you how I wrap my head around it. If this population in the United States was a healthy population, without the high levels of cardiovascular illness, hypertension, diabetes, etc., if it was not so overweight, the force of mortality would have been minimal. We would have not had these deaths. And that's the issue. And public health is failing in its ability to deal with it like this and talk to the people about this is a public health catastrophe. And if we don't wrap our heads around it this way in this particular pandemic, it's going to get far worse in the others. So, again, to really answer your question, the problem here was that along comes this pandemic, this situation. And again, I want to clarify something with you because I remembered about the age, but I want to say something. This was not really a pandemic. This is really an epidemic because you need to understand something. A pandemic, if a classic pandemic moves through a society and the world, it affects every age group. It kills the elderly, it kills the middle-aged, and it kills the young. It is catastrophic across the board. COVID is not. COVID has not affected the children and the infants, etc. So it's not a classic pandemic. But again, in answering your question, we figured out quickly, maybe 3 weeks to a month after this began in February and March, that it's a sliver of the population that is the issue. The elderly, high-risk persons who are overweight, etc., with underlying medical conditions. We understood that. So the question is, in the classic sense, if you were going to deal with this pandemic, I still say the word is epidemic, but let's use pandemic. The way we should have dealt with this was, we should have initially strongly double and triple down protection of the elderly, high-risk populations. Those in the nursing homes, the long-term care and the assisted, and your private houses. We should protect them first. That's where the focus had to be. And then the rest of society, the rest of the low-risk society, particularly the younger persons, with reasonable and sensible precautions, with at least fettered encumbrances by the government, you allow them to live reasonably sensible lives with reasonable precautions, and they go about their lives. Why? Because in doing that, they would be exposed to the pathogen in their mingling, in their socialization, and they will spread the pathogen amongst themselves, and they would co-infect each other, and they would develop natural immunity harmlessly. That's the key. And that's how we've done it for outbreak, for epidemic, for pandemic across time. COVID threw everything out of the window and did it differently. And part of the reason the governments failed to protect the elderly, and still today they are failing, and they do not know. It's either they do not know how to do it, they cannot admit that they have failed, and they still do not know how to do it, or the nurses unions or the old age home unions, whatever, they have the government against the wall, because the government should have stepped in and made sure to make the changes, particularly to prevent staff from entering these homes. The key here has been the staff. I have two in-laws who are in elderly homes in Toronto, and both of them repeatedly are in lockdown situations at various times. Why? Because every time they get the outbreaks down, where many die in their homes that they're in, a new staff member, another staff member will bring in infection again and reinfect the entire home. So the staff has been the rate limiting step, and no one has stopped staff from infecting homes in America, old age homes in Canada, old age homes in Britain. Had they done that in the beginning, strongly protect the elderly in those homes by limiting staff from infecting them, that would have been a way to deal with this. And that's a very important.
Right, but how would you have protected them? How would you have taken care of them? Because the reason they're in homes is because they need that care. Need that
Yes,
care.
but remember, the staff is coming in and infecting them. So I remember in my position, in my job, and I really don't want to get into too much of my government work, but I remember speaking to the high level people, certain individuals, and explaining to them, look, you can't have the staff infecting the people. So you have to have some programs in place quickly and regulations. As an example, and I gave the solutions in my mind what would work. I said, you have some European countries who designate certain floors in certain of these facilities as only for staff. They turn to the staff and they say, once an outbreak starts in the home, so let's say COVID starts and starts infecting the elderly, they said, okay, we would request that you don't go home for 1 week to 2 weeks so we could get the outbreak under control. And you offer them, could you stay? Those who can't, you don't punish them, those staff, you send them home with pay, and they wait until it's done to come back. And those who could, great. You isolate them, you give them the separate floors so that they don't leave and bring back infection again. And if they don't want to stay, you turn to the nursing schools in your society where the young people need the money and they want the experience, and you bring them in to deal with the residents, as well as you designate hotels right next to the old age home, and you let the staff stay there. If they say, well, yes, we can, but we can't be traveling, we want to, you confine them so that they don't leave and bring infection every time you tamp it down. Look, if we would have dealt with the staff, we'd have probably had 10% of the deaths that we had. 10% of the deaths. The staff, I'm not blaming people who are the staff. I'm just blaming the way this was operated, and this was a simple solution. But it still has not been done. Not been done in America, not been done in Canada. And that's where all our cases are. And that's the issue.
Yeah, we just have a little bit of time left. I want to ask you quickly. So I assume that because it seems to me that you would be in favor of vaccinating elderly, frail people. But what we're seeing in the United States, I don't know how it is in Canada, but young people are lining up in droves to get this vaccine. They are so terrified of this virus. What are your thoughts on that?
Well, look. I mean, we are having a discussion and you ask me a question and you're asking me a question, and I presume you want me to be brutally honest. So I'm being brutally honest with you. In my job also, and I have been on record stating it, and I've written now many, many articles that have been published, I have said that if we have managed this without vaccine, we should have. And if there were going to be vaccines, they had to be properly developed and only prioritized for the elderly people who are sick, who are gravely at risk, etc. Not for any young person. I'm on record stating that based on CDC's data, if you are 70 years old and below, 70 years old and below, with no underlying medical conditions, no serious illness, you should not have been a candidate for these vaccines. So I'm talking about from 0 years old up to 70. And I support that statement with your risk of severe illness or death. CDC data, it's almost zero, the risk of severe illness or death. So why vaccinate? So that's the issue. The issue is, right now we're dealing with an experimental vaccine, investigational, They have not done the safety testing. They tell you that in the consent form. When you look at the FDA form, they said this is investigation. The safety testing has not been done. So why would you take a vaccine that has not been safety tested? And we are beginning to have reports of adverse events and even death from taking the vaccine in the CDC's vaccine reporting system. So I'm not making anything up. It's a fact. And for sure, 100%, 1,000%, I absolutely am against any children getting these vaccines because they are low risk of acquiring it and low risk of spreading it and low risk of getting ill. So for sure, unless you put forward a safety tested vaccine for me with proper data done over the years that needs to be followed first to assess the safety signals, then I will not agree with giving our children vaccines, because if this goes catastrophically wrong, they have 70 years of disability or even death to face.
Yeah. Well, Dr. Alexander, we have run out of time. Before I let you go, you want to just kind of give a pitch on anything that you're working on or where people can learn more about your work?
Well, we've published a lot on the American Institute of Economic Research, AIER. We have about 15 different op-eds on all of the topics to do with lockdowns, masks, scientific dissent, etc., mask mandates. But right now, so I appear on all these talk shows, but the recent one on Laura Ingraham on Fox, I stated something at the end. I said, if the government, if the FDA is going forward with trying to vaccinate the children, then we need to put the liability waiver on the table. In other words, if you have a liability waiver, that means no trust. You remove the liability waiver first for parents. Let parents see that you, as the developer of the vaccine, is saying that we trust these vaccines. This is safe. The vaccine developer and the FDA must tell us parents this. If they don't, if they want that waiver still in place for their liability, so that means they're taking no risk and asking parents to just trust them. I say no. Put the waiver on the table and remove it. And then parents will consider it. And that's what we're working on. Right now, we're writing a piece of paper.
Yeah, we've really distorted our sense of risk and benefits with this whole epidemic of COVID-19, as you call it. All right, well, we're going to have to wrap it up. Thank you so much. Paul Alexander, a health research methodologist in evidence-based medicine at McMaster University in Canada, talking to us about COVID-19 14 months later and how we can follow a path forward. And I'll also have links to his recent article in our podcast notes.
Thank you.
And thank you, listeners. Please spread the word on free market discussions like this one. Share our podcast. Become a Heartland Daily Podcast subscriber. Give us a thumbs up on iTunes. It is all really important to amplify the free market message, given the censorship that is taking place today. And I'll be back next week with another topic in healthcare news. This is Anne Marie Schieber.